Hello, everyone. Good morning, good afternoon, wherever you are. Welcome to our webinar today. My name is Thomas von Larcher. I'm managing editor of the journal SN Applied Sciences, and I help to run the meeting today. Today, we have Dr. Neel Sharma from Queen Elizabeth Hospital, Birmingham, with us. Dr. Sharma is a clinician academic in the field of gastroenterology at Queen Elizabeth Hospital, Birmingham. He undertakes clinical research as a lecturer at the Institute of Immunology and Immunotherapy at Institute of Translational Medicine at the University of Birmingham. He has gained clinical and research training in several places, for example, London, Singapore, Boston, etc. And he also serves as a member of the Global Health Workforce Network Education Platform of the WHO. So welcome, Neel. We are delighted that you accepted our invitation to give a talk in our webinar series. Oh, and I should not forget to mention that Dr. Sharma is guest editor of the journal's topical collection, The Clinician Engineer. We will have time for questions after the talk, so please type your question into the chat box as we go, or you can unmute yourself after the talk and ask your question with clear voice. So with this, I hand it over to Neel. Neel, again, thank you for joining us today, and the floor is yours.
Fantastic. Well, thanks so much, Thomas, for inviting me. And I think this is a great opportunity to talk about our work, which is focused on the medical and engineering interface, the launch of the topical collection, The Clinician Engineers. So let me share my screen. This is when everything goes wrong, so I'm going to try. Oh, it worked. Can you see my screen now?
Yeah, I can see your screen.
So now I will press this button.
Yeah, maybe you can switch to the presentation mode.
Yep.
That would be nice.
Can you see now the full screen?
Yeah, we see the full screen. It's perfect.
Fantastic. So we're making good progress. So yeah, exactly like Thomas said, I'm a clinician. My interest is in gastroenterology, but for many years, I've had a real passion around the interface between medicine and engineering. And I want to talk to you about our network, which is the Clinician Engineer Hub, and essentially the reasons why we set it up, what we've done so far, and really where we plan to take this network. So it's all very exciting. So let's begin on our first slide. So when I went to medical school, and I think medical students still to this day get shown this portrait, and this is medicine then, as I've described it. This is the interaction between a physician that you can see and a patient. This was taken in around the 1800s. And when you go to medical school to become a doctor, you get told that the art of medicine is about talking to your patients, so taking a history, asking them questions, and then physically examining them. So these two things are crucial. This has not changed in 2021. So this has been going on for centuries. Once you talk to your patients, once you physically examine them, you are then, hopefully with the knowledge and skills that you've gained, you're able to formulate a possible diagnosis or a number of diagnoses, and then you manage your patient accordingly. But there is also issues with that approach, and we know this. And I think one of the things that we have to do is be transparent, be realistic, and say what actually happens on a day-to-day basis when we see our patients. So the first thing, I already said that if you talk to your patients, i.e. take a history, there can be problems with that approach. Now, the evidence has said, particularly from regulators all over the globe, that one of the problems doctors have is that we speak in medical speak or medical jargon. So we may ask patients questions, but they may say to us, well, doctor, I don't understand what you're asking me. We get stuck because we're not able or we're not trained to simplify things sometimes. And so on the basis of that, we may not be able to have that doctor-patient interaction to the best of our capabilities. The second thing to say is patients are human beings. You know, it is a very interesting and unique and special interaction that we have between doctors and patients, but patients don't have to tell us everything. So we may ask them questions, we may suspect certain things, but they may say or may deny things to be the case. For example, the alcohol history or maybe drug history. They could tell us that they don't drink or they don't misuse drugs, but we could say potentially that biochemically that may not be the case. So you can see how there's limitations just by interacting with patients. Number two, the physical exam. So it gives us some idea, but it doesn't complete the picture. So if I was to examine someone's abdomen, if they came in with pain, I could say, okay, there's definitely pain there, there's definitely tenderness. I will be able to figure out, okay, it may be right-sided pain, so that's leading to one particular condition or a handful, or it could be left-sided, and this is what I'm thinking. But I can't say with definitive accuracy what the problem may be. Also, for example, if someone comes in with weakness, you may suspect a stroke, but you don't know if that stroke is due to a bleed in the brain or a clot, and obviously that dictates management. Heart failure, the same issue. I may be able to guess that someone may have problems with their heart, they may have fluid building up in the legs, they may be short of breath, but I can't quantify it. So ask yourself in 2021, if there are issues with the history-taking process and the physical exam, can you really, with a 100% accuracy, formulate a diagnosis? And I think from my side, the answer is no. And I'm going to explain further on the next slide. So this is what I like to call real-life medicine. This is what we do every day. Now, unfortunately, and I don't know why this is the case, when I was more of a junior doctor, so I'm talking back in about 2010, I realized that I was relying every day on a group of professionals, which are, to me, the silent workforce of healthcare, called engineers. And you may be wondering, what's engineering got to do with medicine? Why is that important for you to be able to do your job? Well, let me explain. So like I said, if someone has abdominal pain, I actually would request some form of imaging. It may be an ultrasound scan, but the picture here shows a CT. And the CT scan and the CT scanner, obviously designed, developed by engineers. If someone has problems with their kidneys, I can give them fluids to help resuscitate the kidney. But if the kidney does not improve, they may need dialysis. And these dialysis machines, designed, developed by engineers. If someone is bleeding within the digestive system, this is what I do every day. And I've actually got a session this afternoon. I do endoscopy, the endoscope, designed, developed by engineers. Without it, I wouldn't be able to look inside someone's digestive tract and figure out what the problem is and treat it. Some more examples. COVID-19, prime example. We've suffered this pandemic globally for almost 2 years now, without ventilators, without respiratory assisted devices. The physician essentially wouldn't be able to do anything for patients because patients with very severe COVID, they need intubating, they need ventilatory support. Take someone who's had a heart attack. We may give you blood thinning medication, so you may have heard of things like aspirin, or clopidogrel. But if the vessels are still significantly blocked in the heart, you would need stenting, so cardiac stents, designed, developed by engineers. And I love having this debate with my surgical colleagues. I tell them, maybe you needed that steady hand of a surgeon before, but nowadays robots and robotic assisted surgery is coming into the theater space. Robots and robotic assisted surgery, all designed, developed by our engineering colleagues. So in my opinion, and it's just an opinion, I'm not saying it's fact, I feel there's a new generation that is essentially developing, and we haven't quite realized it yet, but it's happening. And I've already explained why I think this link is important. We have had many people that have merged clinical medicine with science, so our clinician scientists. We have people that run hospitals, clinician managers. We have people that like to teach the next generation, clinician educators. But we don't have this hybrid form of the clinician engineer. And if we have, and if we're seeing engineering solutions on a day-to-day basis, helping us diagnose and manage our patients, it makes sense that actually clinicians start understanding engineering, gaining some more exposure, speaking to engineers and vice versa, gaining training. And that way, I feel that as we're using devices and diagnostics all the time, we're going to know what the limitations are. We're going to know the areas that we think need improving. And so our engineering colleagues can work with us to develop more innovative and more appropriate solutions. So here we have the Clinician Engineer Hub. I would say it's the first in the world, but happy to be proven wrong, international network that links clinical medicine with engineering. And since its launch in 2019, February, we offer education, research, and industry opportunities for medical students and doctors. So here are our workshops. We all got consent for these photos, in case anyone's wondering, but this was taken at the Queen Elizabeth Hospital, Birmingham. Our eager first batch of students gaining engineering expertise in the clinical setting. Here you can see them being given actually a problem and trying to work through the problem with an engineering solution. We had to move online because of the pandemic, but we did that successfully with webinars. And the advantage of this is that all our educational material is free of charge. So what we do is we bring international experts to us. They're more than happy to teach and train. And medical students from around the world can then view this content free of charge. And I think that's really fantastic because not everyone can mobilize. I've been quite lucky to be able to work in different environments internationally. And not everyone can afford the cost of tuition. So, even for me, I've relied heavily on funding and scholarships because cost of education is so expensive. And these webinars are completely free. No one has to pay, which I think is great. All our videos go on YouTube. So when we started, we had only 2 subscribers. We now have well over 100. So we are building. Our research opportunities are always there. So students come to us and say, okay, well, we've got an idea, but we don't know how to take it forward. And over time, it's taken some time, but actually I think it's been quite fast. We have linked with multiple research institutions within the UK and abroad. And there's plentiful mentors at these institutions that can guide students with their ideas. Our industry arm is also growing. So we linked recently with Cambridge Healthcare Research, more recently Besta Consulting, focusing really on data analytics to start with, but our industry partners continue to grow. We have an advisory board, experts around the world that have that expertise that for me, as I'm still developing, I don't have. And we rely on them and they can provide direction, tell us if we're doing things well, tell us if we're doing things not so well. This is the team. Now, without the team, I don't think this whole thing could function. And literally, these are motivated, dedicated, passionate students in engineering and medicine that have done wonderful things for the Clinician Engineer Hub, and they continue to do so. So any organization, any network needs a good team. They're still hanging around, surprisingly. So this is just great. We held a conference just to test the water, to see how positive this concept would be. What would people think of it? And we managed to recruit speakers from Google Health, Microsoft, Amazon. We gained data analytic information from Twitter, and we hit well over 27 million impressions, which I think is amazing. The World Health Organization even came to give a talk. So this is Adriana that focuses and leads the biomedical devices section of the WHO. She's recently done some great work around devices within these low-income nations and how we can utilize devices to help in healthcare. So I'd encourage you to read that. The New England Journal, for me, this was a gold star. They also were very interested by what we were doing on the clinician engineer concept. So they featured a discussion virtually, which hit well over 6,000 views. We held a hackathon. Students get very excited by the word hackathon. I think I'm a bit too old for it, but they said they wanted to run with this. And so Claire actually is from Canada. She led this. She brought speakers from IBM and they went and they spent a weekend virtually developing new solutions across the medical and engineering interface. The Lancet also has recently featured us, which again for me is another gold star. And here we are, Spring in Nature. This is the whole purpose of the webinar. So for me, if you have an idea, that's great. You can talk about it, you can build that concept, but ultimately people need to know about your idea. And what I realized in the academic space, at least, was that there was no particular area which would allow a hybrid of clinical medicine and engineering. Where would you publish your findings? Even if it's just initial pilot data, people need to know about it. And Spring in Nature were really very much, I would say, enthusiastic and interested about this. And we launched this topical collection. And so, yes, anyone out there that wants to submit their research, even if it's just small data, you know, it's a fantastic journal. I don't think there's any other journal out there that is offering what we're offering. So please do consider it. We're on social media, so at Clinic Engine. We've partnered with EIT Health, and our future plans will continue. Now, COVID-19 obviously has limited everyone in many ways. We are here in the UK in a recovery phase, I would say, but I'm going to hold my breath. I don't know if that will continue to be the case. But what we plan to do is continue with workshops, unfortunately not face-to-face, it will still be virtual. One day, international events, but not at this moment. Research is great. We've recently received funding to undertake our first specific hub-related research study focused on artificial intelligence and gut inflammation, and industry will continue to support us. So I'm going to end there because I think a debate and discussion is more interesting than me. But if you're interested, please visit our website, clinicianengineer.com. We're on Twitter at Clinic Engine. We're also on Facebook. And the junior members of the team wanted us to launch on Instagram. I have no real expertise in Instagram, but we are there. So please do get in touch and get involved. Thank you so much. I'm going to stop sharing now. Yeah, I hope that was reasonable.
It was reasonable. I'm sure. Yeah, thank you, Neel. Thank you so much for this very interesting talk.
Yes.
So, as far as I can see, there are no questions in the chat box, but let me check again.
Perfect. I'm happy with that.
I really like your approach to bridge the gap between medical doctors and engineers. I think that is a very important initiative. And I'm happy to see that you also have support from industry. And yeah, I think that is a great initiative. So yeah, it's a side project, right? It's not your main project.
No, so this is not my sort of primary job. I'm a clinician, so I work in the NHS. So that's my day to day. So I did a clinic this morning and I have endoscopy in the afternoon. So yeah, but I'll be honest with you. I think it could easily be a job for somebody because it is something that needs pushing on a day-to-day basis. And
yeah,
you know, we've thought about this. We've all considered the whole team taking a sabbatical and just pushing this every day. But at the same time, we realized maybe we don't need to do that. Maybe, you know, we allow it to sit there, let it grow, and also push it when it needs to be pushed, you know. But yeah, maybe that's not the right approach to build anything, but we'll see.
No, I mean, your successful conference last year, for example, and the upcoming conference, I mean, that is a clear sign that people are interested in your initiative, right? So I think you should keep it going and promote it wherever possible.
Yeah, absolutely. You know, we have been endorsed by really prolific organizations, and you know, including yourselves, the New England Journal, Lancet, the WHO. So everyone has taken this quite seriously. So just that in itself is really quite remarkable. We all as a team were very happy about that. So yeah, we keep going, but the pandemic puts us under pressure because, well, I won't talk to you about my work contract in detail, but yeah, it became quite busy, shall I say, on that side. But now we're in a calm phase, so.
All right, all right. Yeah, let's discuss details when we stop the recording. So,
Absolutely, yeah.
so I again check the chat box. There is no question at the moment. So yeah, then I thank the audience for attending us, and I thank you again, Neel, for this fantastic talk. It was great to have you here in our webinar series. And yeah, I wish you all the best for your initiative. And thank you again. Bye-bye.
Thank you. Thanks for the invitation. Bye-bye, everyone.